Pain in epigastric, sudden onset, severe pain in epigastric region, radiating to back, aggravated after meals, and relieved on injectable analgesics. No history of pain decreasing on bending forward. History of low-grade fever not associated with chills present. No history of vomiting, altered bowel habits.
Can you please make it full screen?
Sir, visible, sir, full screen, sir.
Not yet. So, okay, please continue.
Yeah, do that.
Yes. No history of vomiting, altered bowel habits, yellowish discoloration of eyes, abdominal distension. No history of any loss of weight, loss of appetite. No history of hematemesis, marina, postural dizziness, syncope. Here I want to know if patient had any history of trauma. Patient was admitted to a hospital, investigated with ultrasound abdomen. So I would like to see the ultrasound abdomen report. Patient was managed with IV fluid and analgesics. Patient was discharged after 5 days with no active complaints. What was the medication that at discharge? I want to know. Post-discharge after 1 month, patient noted sensation of fullness in upper abdomen. In 1 month, patient had any continuous mild pain episodes? I want to know. No history of pain abdomen, early satiety, vomiting. So patient may be having no history of fever, jaundice, melena. Past history of LSCS 3 months back, and no history of any medical illness. Here, any medication history specifically, I want to know. Family history, not significant. Personal history, sleep normal, appetite normal, bowel and bladder habits are normal and regular. Patient is taking mixed diet, and I'm supposing patient is having not any habits. Should I summarize, sir?
Yes.
24-year-old female with no comorbidities had pain epigastria 1 month back, radiating to back, aggravated after meals, relieved on injectable analgesics with low-grade fever, managed at hospital for 5 days, post-discharge after 1 month, having sensation of fullness in upper abdomen with no pressure symptoms. My differentials are acute pancreatitis with pseudocyst formation, acute on chronic pancreatitis with pseudocyst formation, cystic neoplasm of pancreas with the acute pancreatitis resolved. I'll keep a remote possibility of this, sir.
These are your differential diagnosis?
Yes, sir.
Okay. Any other differential diagnosis? For example, I am telling it is a tumor.
Yes, sir.
Presentation of a tumor.
Yes, sir.
Tumor can grow in 1 month. Tumor can have many other complications which can present as a lump after a month. These possibilities are there.
Sir, patient is young age and no history of loss of appetite and loss of weight, so I'm not considering it. Second, sir, patient had pain episode followed by a lump was developed, sir.
The first diagnosis which you mentioned, acute pancreatitis with pseudocyst, I mean, that's acceptable. I mean, it is a single episode of probably 5 days, you said. But why chronic pancreatitis would you even consider in this patient? What clue does she give you about chronic pancreatitis?
Sir, I'm supposing if patient presentation is for the first time, sometimes patient can present for the first episode, sir. Otherwise,
anything, man. But no, I mean, you don't need to give a lot of DDs. Why anything in her history to suggest chronic pancreatitis?
No, sir.
Any diabetes, any exocrine dysfunction, any previous history of pain, any recent weight loss over the past few months?
No, sir. No, sir. No history to suggest chronic pancreatitis in history, sir.
But chronic pancreatitis, acute on chronic pancreatitis, acute pancreatitis or chronic pancreatitis? The disease process.
Sir, this disease process was acute pancreatitis, sir.
No, acute on chronic pancreatitis as an entity.
Yes, sir.
Chronic pancreatitis or acute pancreatitis?
It is a chronic pancreatitis, sir.
Okay, so that's what the point we were discussing. It's a chronic pancreatitis. So this patient
Yes, sir.
doesn't any symptom of chronic pancreatitis.
Yes, sir.
Can we continue?
Yes.
Yes.
Oh.
General physical examination. Patient is conscious, cooperative, and oriented to time, place, and person. BMI is 20.8. Patient is moderately built and well nourished. ECOG status of 0. Breath holding time is 35 seconds. Patient is having no pallor, icterus, lymphadenopathy, edema, cyanosis, or clubbing. Vitals are stable. Just for completion, I want to know if patient any having left supraclavicular lymph node. Inspection, abdomen is flat with the umbilicus central in position and inverted. All quadrants move correspondingly with respiration. No visible peristalsis, sinuses, and gauged veins. Here, if any visible fullness is there in epigastrium. Healthy scar of previous LSCS is seen. Hernial orifices and external genitalia normal. Bilateral renal angles appears normal. On palpation, abdomen is soft, non-tender. Liver and spleen are not palpable. Soft, non-tender, smooth lump with ill-defined margins palpable just below the junction of right costal margin and xiphistoma. And lump is not moving with respiration. Hernial orifices and external genitalia, no palpable impulse. Leg raising chest just for completion, sir. Percussion, dull note present over mass. I want to know whether it is merging with liver or not. Liver dullness present in fifth intercostal space in right mid-clavicular line. Liver span is 13 centimeter. Flanks are tympanic, indicating no ascites. Auscultation, normal bowel sounds heard. Digital rectal examination, glove stained with yellow finger, sphincter tone normal. Respiratory system essentially normal. CVS, CNS normal, sir. To summarize, patient is 24-year female with no comorbidities, had pain epigastrium 1 month back, radiating to back, aggravated after meals, relieved on injectable analgesics with low-grade fever with no jaundice, loss of appetite or weight, managed at hospital for 5 days, post-discharge having sensation of fullness with no pressure symptoms. On examination, patient is ECOG 0, well nourished with soft, smooth lump palpable in epigastrium and not moving with respiration. Differentials are same, sir.
Can you just show us your palpatory findings once? Just get back to the.
Yes,
I
sir.
don't think it's complete. I mean, anything else would you like to, should have been added in this? What are the, when you have a lump in the upper abdomen?
Sir, whether a finger insinuation test is possible or not, sir.
Absolutely. That's important, right? Whether you're able to get above the lump.
Lump, yes, sir.
That will be important, whether it's a liver. Then anything else?
Yes.
Whether it's
On palpation.
forward and left lateral knee elbow, that's not important.
Yes, sir. Sir, knee elbow position only will tell, but
No, but knee not be knee elbow. You can do a left knee elbow, maybe left lateral, and you can just bit more extra tilt. You can make out. So I mean, these two are like definitely important thing. I think they've been added by the center which had the case, but those two are very important in a palpatory findings, right?
Yes, sir. Yes, sir.
What is the size of the swelling?
The size of swelling not mentioned, sir.
Okay, they are not mentioned. Okay.
Yes,
You think
yes.
it should be mentioned?
Yes, sir.
You think it should be mentioned?
Yes, sir. It should be mentioned, sir.
Okay. What is ECOG performance status?
Sir, Eastern Cooperative Oncology Group for assessment of the performance status of the patient, sir. Is 0 to 5. Yes, sir.
Is it okay for this patient?
Yes, sir. Patient, maybe, sir, now patient is pain-free. That's why patient performance status is 0, sir.
No, it's an oncology group. No, you're getting the
Yes, sir.
question. Is it okay in this patient? Is there any other performance status parameters you can rely on in benign diseases? Okay, you are not suspecting malignancy here, no? So the validation of
No,
that
sir.
in benign disease are different. Okay, so that you please
Yes,
leave it now. What is your final
sir.
differential diagnosis now?
Sir, acute pancreatitis with the pseudocyst formation, and rest two on lower possibility, sir.
No, second, you leave it for the time
Yes, sir.
being. Okay.
Yes, sir.
Consider the first acute pancreatitis with pseudocyst and tumors. Okay.
Yes, sir.
Also request comments from other panelists. Can we go ahead with these two diagnoses? Yes, Dr. Shiraz.
Okay.
Yeah. I think you are muted. Yeah. Dr. Shiraz, you are muted.
Okay. Yeah.
Yeah.
Sorry. I forgot to unmute it. Dr. Gural, with this brief history of 1 month pain, abdomen, and a lump
Yes, sir.
in the epigastrium, we need to keep all things, the structures which are lying in that part of the abdomen, in mind when you're making a differential diagnosis. So if this patient walks into my OPD without looking at the investigations, I would keep every possibility that it can be, as you rightly said, it can be an acute pancreatitis insult with a cirrhosis formation. It can be any mass arising from a stomach, liver, pancreas. These are all organs right over there, right? It can arise from
Yes, sir.
mesentery. So when we are going for a differentials in an opening statement, we keep all the possibilities. Then depending upon the priority. So it can be a very well a cystic gist of the stomach, which got a hemorrhage and causes a pain and which aggravates on eating food. So it can be anything at the moment. It can be a benign thing. It can be very well a malignant tumor. Now, I would say that a tumor which is palpable, is very unlikely to be an adenocarcinoma of these structures there. So it can be any sarcoma. It can be anything. So we will not go only with acute pancreatitis cirrhosis formation. And you're very specifically put a cystic neoplasm of pancreas with acute pancreatitis resolved. When you're looking at a differential, you keep a broader umbrella. So then when we narrow down once when investigations are revealed to you. So don't focus on one, epigastric mass you say in the pancreas. It can be a liver cyst, it can be a liver tumor, it can be a
Yeah.
stomach sarcoma, right? So go with a broad
Yes, sir.
mind openness and then we narrow down on it. Yeah.
Yes,
Shall we
sir.
go for investigations, please?
So what do you want to do with this
Sir,
information?
first I want to review the ultrasound, sir, done during first admission, sir.
Why you want to review the previous ultrasound?
It will hint about the diagnosis. What was the underlying possible etiology that time, sir? Why patient got pain and admitted to the hospital?
No. See, now you stick on to your differential diagnosis, what we have discussed. The
Yes,
wider,
sir.
you please specify why you want to know the ultrasound done at that point of time.
It will hint about, sir, patient at that time pancreas, it was enlarged or it was any fat standing, any
Let me
peripancreatic.
explain further. Are you sure that that time there was no lump?
No, sir. Patient may not be aware of the lump. It can be present before also, sir.
So it can be present that time also. That was the point of discussion. Okay.
Yes, sir. Yes, sir.
Well, one, presence of the same lump that time. Okay. Second,
Second, sir, ultrasound will tell if it organ of a region, if it is from the liver or it is from the pancreas, or patient is having associated gallbladder stones, or if any mesenteric cyst also it can tell.
Dr.
no,
Gurulal,
don't go first.
say
One
that
is
if
with
a
respect to your
patient,
differential diagnosis. What are the things you want to know at the ultrasound, in the ultrasound done that time? One, you told presence of the same lump. Second, gallstone. Third,
What's
you told acute pancreatitis, pseudosis. What would have been the findings that time if it is acute pancreatitis?
pancreas on ultrasound it will show heteroechoic ecotexture. It can show peripancreatic fat standing. It can show collection, peripancreatic, or presence of any intra-abdominal collection, any presence of ascites, or patient if having any underlying CBD stone that was causing it can show dilated CBD and IHBD, sir.
And what else? Can show pleural effusion also.
Yes, sir. It will show pleural effusion also. Yes, sir.
Oh, yeah, Dr. Phani.
Gurulal, I would suggest go with a systematic approach. If a patient comes to your OPD with this history,
Yes, sir.
obviously the blood investigations first, right? You'd see what is the hemoglobin, what is the liver function test, whether there's any derangement in the pancreas, amylase, lipase, inflammatory markers. So go systematic, don't jump on an ultrasound. The patient has a lump, you will see an ultrasound first. So systematic way of examination is, or even investigations, you ask for a blood investigations and then you come to the radiology. So what do you think, would you expect an abnormality in this kind of patient? What blood parameters you would ask for? That sort of approach. And then ultrasound is in this patient is most likely going to not only give you some of the clues what we are dealing with, and then it will also guide you what is the further investigation you would like to go for, cross-sectional imaging. So it's basically ultrasound is nowadays an extension of clinical examination in making your further future plans, right? So don't jump on the first radiologic investigation, rather go systematically. Yeah. Okay.
Yes, sir.
So what do
Sir,
you
at present,
expect with blood investigations? What blood investigation you ask for, or you would look at? They would have done blood investigations. What would you look for, and what would you ask for more?
I would ask for a hemogram, sir. In that, I will like to know if any elevation of total leukocyte count was there, that patient had fever that time. I will ask for RFT to know the renal status of the patient, LFT, and amylase lipase,
What do
sir.
you what do you expect in LFT to look for?
As of now, patient is having lump. It can cause compression over the CBD, and it can result in obstructive picture of the LFT, sir, in raise of ALP in form or bilirubin.
Okay. And amylase lipase, you said, yeah?
Yes, sir, amylase lipase, yes, sir. And
Any
RBS
other
baseline of
any other inflammatory marker you would look at?
yes, CRP we can go for, sir,
Yes. Yeah. Okay.
and
Good. So
RBS I will look for.
can we have the investigations, please? Yeah.
Yes, sir. Hemogram counts are elevated 12,500. Hemoglobin is borderline 9.9. RFT is normal. Electrolyte is normal. Potassium is borderline. Amylase normal. Lipase normal, sir. On LFT, mild elevation of ALP is there. It is elevated, sir, showing biliary obstruction. Albumin is normal. Iron are normal, showing a normal liver synthetic function. CRP is elevated 250.
Significant elevation of CRP, isn't it? Yeah. Why do you
Yes,
think
sir, more than
hemoglobin
150.
Why do
So
you think
this
hemoglobin?
investigation is at that point of time. So what is your inference with this investigation?
With young age patient can be having only cholelithiasis also, sir. That time, if lump was
So
not there,
just this
it was
investigation, this blood test, what is your inference, man? Just I think, what do you see? CRP is elevated. That's the positive thing, na?
Yes, sir.
What does that mean?
That means acute inflammation was there, sir,
Like
that time.
some acute inflammatory process.
Yes, sir. Yes, sir.
Based on 195 alphas, do you think you can make an interpretation if there is biliary obstruction?
No, sir, it indicates, sir, it is not direct evidence will be by imaging only, sir.
So mild elevations, at least not even more than 2 times like that. No, you can't really come to conclusion based on that.
Yes, sir.
With this investigation, if it is pancreatitis, was it severe or mild?
Yes, sir, it was severe, sir. CRP is more than 150, sir.
Hey, don't say such things, man. Is the severity of pancreatitis, what is it decided based on?
Sir, on based of organ failure, sir. Yes, sir. I will not tell, sir.
Then
Yes,
why
sir.
will you say based on
Yes, sir.
CRP
Yes,
or
sir.
amylase?
Yes, sir. It's based on organ failure, sir. We can't conclude that it was severe pancreatitis.
No,
I'm
this
thinking to
patient.
give you an idea, was she stayed only 5 days in the hospital. No, you don't have, and at least there's no history of organ dysfunction. So if at all it was a pancreatitis, mild pancreatitis.
Yes, sir.
But your amylase lipase is normal here, right? So what else? So what could have been the cause of pain with an elevated CRP?
Suppose you are differential diagnosed as cystic neoplasms, can it or some other pathology which can lead to the rise in CRP?
Yes, a patient can have an cystic lesion also, which is inflammatory, sir.
So the point is, unless you get the imaging or clinical examination finding at that point of time, don't assume that this patient had a acute pancreatitis that time he presented with a lump. Okay.
Yes, sir.
The typical history is fine only if you have exact findings at that point of time. Okay, there is a chance that you might be palpating the lump now. It would have been there. Patient got discharged. Okay.
Yes.
So you want to see the ultrasound report at that point of time. Is it available?
This is the old ultrasound.
That point of
Yeah,
time?
read-
Yeah, at presentation, at first presentation.
Okay, first presentation. Okay. So what is your inference?
read the report, particularly pancreas later.
Pancreas normal in size. Main pancreatic duct is not dilated. A heterogeneously hypoechoic solid-looking lesion with inflammatory thickening of adjacent fat measuring up to 6.4 into 5.9 centimeter is located in anterior and inferior to pancreatic head, adjacent to pancreaticoduodenal groove. Spleen is normal. Gallbladder, one small mobile calculus is located within the gallbladder lumen. CBD is normal, sir. Liver is enlarged. IHBD are not dilated. No focal liver lesions.
Please tell your diagnosis.
It can be a inflammatory mass also, sir.
No. You please listen. Okay. Was it a severe acute pancreatitis at that point of time?
Uh,
No, you get this ultrasound report LFT and that presentation at that point of. This was the ultrasound that point of time. Is it
Yes, sir.
acute pancreatitis?
Yes, sir. Inflammatory thickening of adjacent fat is there, sir. Heterogeneous hypoechoic. It can be necrotic collection also.
First presentation.
Yes, sir. Acute collection patient can have, sir, within first 4 weeks.
So you
the
tell the
patient is-
possibilities
patient
one
is
by one.
admitted now, if the patient is admitted now in the hospital with the pain abdomen and they do an ultrasound and get this report, it's not a necrosis of pancreas because you don't get a necrosis on the same day, right? It will take some time for the formation of the VON. So it cannot be the presentation ultrasound of a VON unless they have an episode of pain or a forgotten trauma in the past. It's usually more
Yes.
seen in children. So if it's a presentation patient coming, you walk into a casualty and you do an ultrasound like this, you cannot label it as a VON. It can't have a pain and the VON is diagnosed on the ultrasound right at that. Necrosis takes time. It takes 3 to 4 days for it to get blood supply, ischemia, and then leads to necrosis. And so it takes a bit of time radiologically to appear in such a well-defined lesion on ultrasound. So I won't label it VON if a patient walks in the casualty with this ultrasound report, right? So we keep that in mind unless it has happened in past and patient hasn't reported the pain incident, and now we have a well formation go on. So what do you want to do next?
Next, sir, I will go for CCT abdomen to characterize the lesion, sir.
So this was the ultrasound at that point of time. So you are straight
Yes.
away going ahead with CCT.
No, sir. At present,
The
ultrasound first I will see.
problem
Yes,
is
sir.
this patient presented with
Yes, sir.
not so severe symptoms and got discharged in 5 days. If you are diagnosing it as pseudocyst now, pseudocyst is associated with a severe acute pancreatitis more often or mild acute pancreatitis.
Yes, severe acute pancreatitis, sir.
So you think this patient's history is suggestive of severe acute pancreatitis at that point of time?
No, sir. Patient got discharged within 5 days, sir. No, sir.
Even if it's a pancreatitis symptoms, this patient had mild symptoms related to pancreas. Now you did the ultrasound at that point of time, you found a lesion here. So you
Yes,
please
sir.
tell the differential diagnosis now. One, is the tumor a possibility?
Yes, sir. It can be a possibility. Yes, sir.
Is pancreatitis still a possibility?
With only fat staining is in favor, let it can be sir, pancreatitis also otherwise. No, sir.
So it can still be related to pancreatitis, whether primary or secondary. Okay. Now you please tell what you want to do next.
Present ultrasound, sir, after in this admission.
Do we have it?
No, we didn't do an ultrasound when presented.
Okay. So you want to do ultrasound. So ultrasound is not available. What you want to do now?
Next, sir, I'll go for a CCT abdomen, sir. In this case, I will do pancreatic protocol because we don't know, sir, what is the nature of this lesion in pancreas.
Okay. So do we have this CT?
Yes, Dr. Gula, you can control the screen.
This is the non-contrast phase axial section of the abdomen. Liver appears to be normal. There is no calculi or visible in gallbladder. And ultrasound is diagnostic for gallstones, but here also. There is no any evidence of calcifications in the pancreatic parenchyma. Head of the pancreas is bulky. Yes.
Please describe what are you seeing and tell your diagnosis.
There is the evidence of heterogeneous hypodense areas also there with the calcification, likely in the head of the pancreas, head and uncinate, sir.
Where is the calcification in the head of the pancreas and uncinate? Where is
That lesion, sir. Here it is hyperdense speck is there, sir.
No, the calcification you are seeing is in the suspected lesion or in the pancreas.
Sir, it is suspected lesion, sir, not in the pancreas, sir.
So what clue you are getting from this?
I will look for contrast phases and then, sir.
No. What clue you are getting? Is it something giving you a hint? Now, how often you get calcification in a CT in a lesion like this? So what is your differential diagnosis now?
Lesion with the heterogeneous and peripheral calcification, young age, I will think of solid papillary neoplasm, sir.
Now you go to contrast CT.
Yes, sir. Celiac origin I am able to see, common hepatic, splenic artery, There is a heterogeneous mass with the hypoenhancement and mild peripheral enhancement is there, sir.
Oh, that is not enough. No, your CT examination is completely not in order. Please read the CT carefully and please tell the finding. What are the things you want to look in the arterial phase?
Yes, sir.
Is
Arterial and
important in this patient?
SMA appear to be normal, sir.
No, you leave the SMA. You see what is your differential diagnosis? You have two differential diagnoses. Now you examine the CT and tell systematically what are the things you will see and what is there and what is not there. Do you have ascites here?
No, sir. No evidence of ascites. No evidence of ascites, sir.
Liver lesions?
Sir, liver lesions, arterial phase, sir. No evidence, sir. Portal phase again, I will look at, sir.
Okay, now you please tell about the pancreas. Are you seeing any pancreatic lesion? So is this
One
CT acute pancreatitis at this point of time?
No, sir.
Why it is not?
Pancreas, the rest of the pancreas contour is maintained. No evidence of any fat standing is there, sir. Yes, sir. No any peripancreatic collections.
Are you seeing the pancreatic fascia and CT? Investing layer of pancreas. It is very clearly seen and it is intact. In the body tail region, it is clearly intact. Okay.
Yes, sir.
Now you
Yes,
come to what you're seeing and describe the lesion, the location, the approximate size, the nature of the lesion, additional findings, lymph nodes in the region and its relation to the organ of origin. Please describe all this.
Maybe you can see the portal venous phase also and then describe.
Yeah.
Yes. There is no evidence of liver lesion, sir. Right and left portal vein normal, main portal vein normal. There is a heterogeneous mass with the central non-enhancing area involving head and uncinate process of pancreas. No any evidence of lymphadenopathy. It is present below the splenoportal confluence.
Once you
SMV,
finish your
sir.
reading, please tell, okay, that you have finished.
Yes, sir. Yes, sir.
Better to
SMV.
start off like it is arising from the head, body, neck, whatever, man. Like that you start and this thing, no? You've had a good
Yes.
look. So go like systematic. Yeah, it should be like a story. There's a lesion arising from the which part of the pancreas. And then of course the heterogeneity that you
And sir,
described.
there is no background PD dilatation in body and tail of pancreas, sir.
Did you finish?
Yes, sir.
Okay. Now you please tell tail and body of pancreas normal.
Yes, sir. Normal, sir.
You go to the portal vein and locate the uncinate process and tell whether it is normal or abnormal. Look at the portal vein. Okay, come down. Show the uncinate process. You look at the uncinate process. Yes. Come down. Is it uncinate process abnormal according to you?
No, sir.
Then why you
It
are
is,
telling it is the uncinate process and head?
It is arising in the body of the pancreas, sir.
Head part, you look at the portal vein, see the right
Yes,
side
sir.
of the
Yes.
vein, look at the pancreas and see is it arising mainly from the head or somewhere else?
No, like I said, it's on the body and like the part of the pancreas anterior to the portal vein, some people call it the neck also, right?
Yes, sir.
From that area, it's describing. Anything unusual about this? So, two important things. One is the calcification in the lesion, which is against pseudocyst, right? Acute pseudocyst, you would not expect calcification. Would you say?
Yes.
Would you agree?
Yes, sir.
And there's a lot of inflammatory fat stranding around the lesion. There's a lot. If you see the, did you say that actually when you're saying an ultrasound fat stranding, that's not usually an ultrasound feature. They'll just say thickening, inflammatory thickening. This is a lot of fat stranding is there around the lesion. There's
Yes, sir.
some concomitant inflammatory process as well.
You want to go to the other phase? And quickly tell your diagnosis, please.
Yes, lung fields appear to be normal.
Okay, leave the lung. Come to the abdomen.
Sir, with this description, first possibility I'll keep pseudopapillary neoplasm. A young age CA pancreas I'll keep very remote possibility, sir.
Not CA pancreas, adenocarcinoma pancreas. Okay.
Oh, yes, sir. Adenocarcinoma of the pancreas.
Please tell your final differential diagnosis.
Solid papillary epithelial neoplasm and second CA adenocarcinoma of the pancreas.
Okay, still you are considering any benign disease? Can it be a pseudocyst or sequelae of acute pancreatitis?
Less likely, sir.
No, but considering because of the location on the neck, inflammation around the lesion.
Yes, sir. It can be a possibility, sir.
So definitely in this, based on this imaging, at least what the second one, which was some setting under the setting of chronic pancreatitis, PD disruption with a evolving fluid collection in the lesser sac. I mean, now evolving into a WPN. I mean, that based on purely on the imaging, I think that's something we would consider. Though solid papillary neoplasm, something like that, yes, based on the age and all that, it's possible. But the other possibility is also there. So, any further investigations, or would you like to make a plan of management already?
No, sir. Now I will like to look for a CE and CA 19.9 levels also. And next definitive diagnosis is not there. I'll go for EUS plus FNA, sir.
I mean, don't tell the unnecessary investigation. Like there are a lot of tests, a lot of possibilities. CA, how will it help you in this case? I can do AFP also. What is the point? So in
Cystic
the
neoplasm, yes, sir. Not think, yes, sir. We're not
even in
thinking
the
of
DDs, no?
Yes.
In the history, what I was telling is, see, in one clinical examination, anything is possible, but based on the history you have to stick to some 2, 3 only. There's no point telling some, it could be this, it could be that, anything. What is fitting in only, you should tell. And that way I appreciate what your initial lead is. Okay. Did you ask for an EUS or you want an EUS
Yes,
or
sir.
young
EUS plus, sir.
patient you'd like to directly do some resection or something like that? Or would you like an EUS in this patient?
I'll like to do EUS for definitive diagnosis before going for
Okay.
gallbladder standard anechoic with sludge, CBD normal, pancreas bulky in head with the heterogeneous ecotexture. PD is normal. There is isoechoic to hyperechoic soft tissue lesion 4.3 into 4.1 centimeter in peripancreatic region. There are few perilesional lymph nodes. EUS guided FNAB done from the peripancreatic soft tissue lesion. Aspirate sent for cell block and cytology. Yes, I want to know what was the biopsy report. Yes, impression features are suggestive of a solid pseudopapillary tumor.
Gujral, basically, I mean, in this case, definitely, I would say, let's see if the other panelists agree. Definitely, because the atypical, there's a lot of inflammation, and there's some suspicion of the calcification. I would consider an EUS, but normally, if it was a young fit girl like this with a resectable solid mass in the head, which you're thinking of cystic neoplasm, EUS would not really be mandatory if you're not considering an inflammatory pathology.
Yes, sir.
What do you say, Biju?
Yeah, I would consider in this patient, I would consider US.
Definitely.
Otherwise, if they're very typical with the history is very typical with no acute pancreatitis history, then may not be required. What are the investigations which can be helpful in this situation? Let us say if you don't want to do US, what else would help? In this situation, which is the best cross-sectional imaging?
For cystic, sir, then MRCP we should have gone first. Sir.
MRCP. No, in suspected rare pancreatic tumors, which is the best cross-sectional investigation of choice?
You mean MRI or MRCP?
Yes, sir. MRI abdomen with them.
MRI abdomen. Okay.
Yes, sir. MRI abdomen, sir.
So now, what is your diagnosis? What is your final diagnosis?
Final solid pseudopapillary epithelial neoplasm, sir.
Okay, now reviewing your history overall, what would I have heard in your presentation and your summarizing and making a diagnosis? What was the error happened? So you straight away diagnosed as pseudocyst pancreas. So what happened?
Patient may not be aware of the lump before. I should have asked the patient if.
The message is many of the chronic patients,
Yes.
patients with chronic issues can present with acute symptoms. That may be their acute presentation. Point number 2. The critical point in this case is if you are diagnosed pseudosis, the patient's 5-day history of mild pain and discharge from the hospital immediately after admission was not corroborative. Third, in between, she was not very sick and admitted in the hospital and she was improving well. Okay.
Yes,
Fourth is you palpated actually a lump in 4 weeks. Okay.
yes, sir.
It can happen, but 4 weeks you clearly palpated lump of a sufficient size. Okay.
Yes, sir.
This is the age.
Yes,
Okay,
sir.
so all these, so always put a very broad possibilities because clinical medicine is like that. Okay, so that was the error happened. So do not jump into a conclusion. There was no, actually, if you take the history also, this was not the typical history of a acute pancreatitis and a pseudosis. Okay, fine.
Yes, sir. Yes. Sir.
Now what you want to do next?
Now, sir, after At pre-anesthetic checkup, I'll plan patient for surgery as lesion is located in neck. We can go for Whipple's pancreaticoduodenectomy.
Wait, Gurlal.
Or second option, central pancreatectomy.
Dr. Gurulal,
Yes,
forget about the PAC checkup and all. From a surgeon's point of view, what things you looked at for this particular tumor at a particular site? What is in your mind? Which operation you're going to comprehend in mind, and what difficulties you are anticipating? Is this a straightforward operation? Do you feel
no, sir.
difficulties? You would like to do something more?
Patient had acute episode, sir. So
So there was a
it will be a,
yeah, you would
it
like to
will,
repeat the CRP to see whether
yes,
the
sir.
local inflammation has settled
Inflammation
down.
is,
Because when you're going to operate in that area, you want the areas to be kind of, not very hot to make your
yes, sir.
surgery. Now, from the
Yes.
from a surgeon's point of view, what are the things you looked at CT scan?
Sir, look for
Mind. Is there going to be a difficulty in this operation, or what operation you are comprehending?
it will be central pancreatectomy, sir.
Central pancreatectomy?
Or as it is close to, it is in the neck of the pancreas, Whipple's better option, sir.
So, what do you think of the structures you looked at in the radiology and CT scan?
Portal vein, yes, sir.
Which muscles
SMA,
were so SMA you have ruled out. It's away from SMA. It's not arising from the ansonate. It's from the superior border near the head and neck. So what are the important things which did you look at the common hepatic artery? Are you happy that the celiac axis and common hepatic artery is free? Did you look at the portal
yes, sir.
vein, the upper and the lower end? Do you have a portal venous phase? Well,
Yes,
okay,
sir.
you're seeing that the lower end of the portal vein is okay. The SMV spleen junction was okay, or was it compressed?
Uh,
Do you think the
Sir,
tumor was extending to that area?
SMV, I couldn't make out at that time, sir. Splenic vein, portal vein junction was normal. Celiac was arising before and common hepatic artery away, sir.
So you feel you're suspecting some difficulty in this operation, or do you think it's going to be a straightforward operation?
No, sir. Patient had a acute inflammation episode, and second, CBD is not dilated. PD is also not dilated, so it will be a difficult surgery, sir.
It will be a difficult intro. Probably you need a more expert hands, and
Yes, sir.
you will anticipate a more. Do you anticipate more post-op complications in this kind of a Whipple's operation or extended Whipple's, or you feel is going to be a straightforward outcome?
No, sir. I'll expect more complication in post-op. The patient are high risk for post-operative pancreatic fistula, sir.
What
Yeah,
study
just
you want to
giving
consider in this patient? Oh, sorry, please continue. Dr. Shiraz, yeah.
Yeah, that's okay. How will you consent this patient? This patient is staying in your OPD. She's a young girl. How will you consent her for operation, and what complications you will explain to them? What will be your kind of communication?
Sir, I will tell patient. I will tell the patient is having mass in the pancreas, which is having malignant potential in long run. At present, it is most likely it is not a malignant, but on long run, 15 to 20% chance it is having malignancy. And I'll plan for pancreaticoduodenectomy. It is a complex procedure. It will require around 5 to 6 hours, and chances of intra-op bleeding, post-operative hemorrhage, and post-operatively pancreatic fistula, which will require a prolonged hospital stay, or enteral nutrition. That I will explain to the patient, sir. And biliary leak, very less.
I'm the patient. I'm going to tell you, doctor, do you have a cancer?
At present, by scans, it is not a cancer, but in future it has a potential to go for malignancy. SPEN very less likely for metastasis, sir, but some reports are there, like some 2 to 3% it can have metastasis, sir, also.
And doctor, do you think this is a major operation, and can I die with this operation?
Yes, sir. If It
Don't
has a
tell me,
mortality
sir,
of
I'm a patient now. You're talking to a patient, yeah? You're a consultant and you're talking to a patient. Yeah. How will you communicate this? How will you break the bad news and how will you reassure your patient and but you tell the complications and all?
has a mortality of around 3% and morbidity is more around 5 to 30%. But high volume center,
When you're talking to the patient, don't tell them morbidity and mortality. They don't understand these terminologies. Tell them in the straight language, the pure straight language. If they're Hindi speaking, Hindi, English, whatever, but it should not be the medical jargons. Yeah. So the
yes,
communication
sir.
is a key. When you are counseling a patient, if a 25-year-old girl comes for a Whipple operation, the communication is a key. It's not the operation. It's the communication in the OPD when you prepare your patient and the family for this major operation and how will you counsel them. The lack of communication is the majority of the time is a problem we face in the post-op and the complications arise. So you anticipated this patient is going to be a challenging operation. You anticipated the post-op complication is going to be high because the normal pancreatic duct, not a dilated CBD, so high incidence of leak. So if you prepare them well ahead, and then you tell them that there's a risk of a death due to various complications in these patients, the risk is you can't tell them 3%. The people don't understand percentages. So you tell them if I operate 100 patients, 2 to 3 patients may die after the operation. Yeah. So
Yes, sir.
tell the percentages and mortality and morbidity. So communication in a very, very normal local language should be done in this patient, right? And you anticipated that the challenging operation is not a straightforward operation. You need an expert hand, right? For
Yes,
for
sir.
for, for going ahead with this operation. Yeah.
Yes, sir.
Other comments, please, sir.
Dr. Shiraz, sorry, hello. Yeah, please continue. I interrupted. Yeah.
No, I'm done, sir. You can go ahead,
Oh,
sir.
okay. Dr. Gurlal, how do you decide on Whipple or others? What are the surgeries possible? Okay. Whipple's operation is basically designed for aggressive malignancies. Okay.
Yes, sir.
So, do you have any other option in this patient? Is it a malignancy we are dealing with?
But it is other options are enucleation, sir. But with this size of tumor, it
Enucleation. You forget about
Yeah,
enucleation.
don't get into this.
yes, sir.
How much of pancreas is involved? Almost going to the posterior capsule. How will you enucleate? You'll have a major pancreatic
Yes, sir.
leak.
Leaks.
Don't.
Yes, sir. Yes, sir.
What are the possibilities in this? What else is? There are a lot of possibilities. I mean, 2, 3 options are there. That's why he was asking.
Peoples and second
No, in a
central.
child with a not so aggressive malignancy, will you search for any other surgeries in that location?
It,
You want to look at the CT again, you can tell. What are the surgeries possible? And how your intraoperative assessment will decide that. See, in a
others,
pancreas, we all want to remove only the pancreas. Okay. So
yes.
you are removing the gallbladder, bile duct, adjacent duodenum out of compulsion, especially in this. So looking at the CT, looking at the disease, nature of the disease, you have a biopsy. Do you have any other option? That is what the point of discussion.
Other options are
I
duodenum
mean,
preserving.
yeah. You yourself mentioned when you're
Yes.
you're reading the CT, it's from the body. In a
Yes, sir.
patient with a lesion occurring in the body, a low-grade tumor, I mean, would you consider Whipple's?
Central pancreatectomy, sir, will be option, sir.
Central pancreatectomy. What about a distal pancreatectomy? Do you think?
If but distal stump is more, sir. So we'll not go for distal pancreatectomy, sir.
But still less morbid than a Whipple's, right?
Yes, sir. Less morbid than Whipple's.
Yeah, because undilated duct, you're worried about a post-op leak. You have the head and uncinate are absolutely normal.
Yes, sir.
So in fact, in this patient, like I think that's what Biju is saying. All three, I mean, Whipple's is I would really not consider for that patient. What do you say, Biju and Shiraj? I mean, it's a tumor lesion occurring in the sort of neck and proximal body.
If we get a margin from the medial side, then obviously, yeah, that's one option.
Yeah.
But you must understand that any operation in this area is going to be difficult. If you're contemplating a central pancreatectomy, I would say that apart from studies have shown that if you preserve the head of the pancreas and the duodenum, the long-term sequelae for liver is somehow less. Post-Whipple operations, the liver becomes really steatotic in patients, particularly young patients who's going to live next 60, 70 years. How the liver is going to take that burn is always a question in our mind. But central pancreatectomy also with a long head and tail, body and tail with an undilated duct will give you probably the leak-related complications similar, but probably have less long-term sequelae for the liver dysfunctions. It's going to be a challenging operation whether you contaminate a Whipple. It won't be a simple Whipple, that you won't be able to tunnel the SMV junction in this area because that's the area where the tumor is located. So you're going to go right left of the normal way we tunnel for Whipple's operation. So central pancreatectomy always in our mind, definitely if possible, but technically challenging. I will keep a very prepared theater staff for this operation if we have contamination. It's not going to be a simple operation.
So Dr. Gurlal, your suggestion should have been, I consider these three possibilities, and intraoperatively, the critical point is to assess the portal vein area and where exactly the margin coming. Sometimes there will be small discoordination between the right border of the tumor with respect to the head, especially in large lesion, because this lesion is located at the upper border of the pancreas in the neck. So there may be some, so it is better that in this young age, you shift more, your surgery should be shifted more to the left than to the right.
Absolutely.
In case of you have an option. So I would not straight away go ahead with the plan for Whipple pancreatectomy. I may still opt for a distal pancreatectomy rather than a Whipple, even if it is extended to the right side, because this is not a very aggressive lesion. And if multiple anastomosis needed, that's what my suggestion is.
Absolutely. I agree with that. And one point which Dr. Shiraz was making, that's, I think, something you should have picked up, Gulal, that there's a lot of inflammation. You're dealing with a benign tumor, so I would wait for a few weeks before going in for surgery. I mean, the post-op recovery and morbidity would be much lesser that way.
Yes, sir.
So can we invite a discussion from other panelists and anything in the chat box? Yeah. Other faculty can comment. We invite a request discussion from other faculty as
Nice
well.
discussion, Biju. I think it was a very nice discussion. I have only one of few suggestions. I think one is in the differential diagnosis, he only talked about pancreas. You should also consider liver and stomach in that same area. I don't know. That could have been at the history. Later on, I'm sure it's a different thing. That could have been one of the suggestions. Overall discussion, I think, was focused on a SPEN, and I think that is a solid cystic tumor. That is fine. And your last discussion about what kind of an surgery we should do. So I think we should always go for a little more conservative on the right side and go more on the left. So I agree with that. If possible, I think we should explore that.
Thank you, sir.
Good morning, Biju. VK Kapoor here.
Yes, sir. Yes, sir, please.
Sorry, I joined very late today because I was traveling. So I only know that this was a case of a pancreatic cystic neoplasm. I won't say anything, but only thing I would add, because I joined late, that the student mentioned enucleation. Enucleation is an option only in insulinoma, not in other cystic neoplasms. And then also, as Dr. Phani, I think, pointed out, that you have to see the size, you have to see the location in relation to the main pancreatic duct, whether you run the risk of creating an external pancreatic fistula. So students, if you want to read more about other pancreatic neoplasms other than PDAC, please send me a mail, vkkapoor.india@gmail.com. In the subject of the mail, write cystic neoplasms of pancreas. I'll send you the chapter on other pancreatic neoplasms from my book on pancreatidorenectomy. Thank you.
Dr. also, sir.
Yes. Good morning, Dr. Biju. Hello.
Good morning, Dr. TD. Good morning. Good morning.
Yes. So you have already emphasized the acute pancreatitis and the pseudocyst, and The only problem is only one diagnosis is made in the differential. Second important point is reading the CT scan. So it was looking at pancreas was enhancing properly and head was looking normal, and it was also looking normal. Though tumor are going up down, and both since both head and ancillate was looking normal, well enhancing. So keeping the option of PD as a first choice in all the complications you are describing. So first choice was not acceptable at all. And CT reading is also a little bit problematic because of the sheer look, you are seeing the pancreas which is enhancing, head is enhancing properly. So there is no involvement of the head at all. And then as everybody agreed that either we can go for distal pancreatectomy, or if you can preserve a good amount of pancreas, then you can have a central pancreatectomy where since he is young. So you can do any either PJ or even dunking of the pancreas in the head or in the sorry in the stomach or in the jejunum. So these two options would be preferable rather than going for VPs in a young girl which has such a huge tumor and everything suggesting going towards some more complications and waiting for some more time to let the inflammation which has occurred maybe because of any reason to settle. That would be my comment. Thank you.
Thank you. Dr. Shastri, sir, do you have any comments?
Yeah, nothing much except, yes, the initial differential diagnosis should have been much broader, not just confined to pseudocyst here. Second, he does need to improve on his CT reading. CT reading left much to be desired. Well, the final options of management, where you can have any amount of discussion. It's important to know what are the options at this stage and how you would choose one over the other rather than giving a one particular choice. All in all, it requires a little more improvement in his presentation, interpretation of the clinical parameters and even the imaging. And that is what I thought was lacking. Thank you.
Thank you, sir. Any other panelists? Any other faculty? Yeah. So what you need to do is, Dr. Gurlal, senior
Yes.
presentation as all faculty suggested, you always keep a wider perspective. Okay, nobody is going to criticize you for including more, but there will always be problem when you do not include your restrictive diagnosis, differential diagnosis is not acceptable at this stage of history and examination. Okay, that is point number one. Second, regarding the CT, especially in pancreatic tumor, when you suspect a lesion at the neck, the critical areas you have to look very carefully. For example, superficially you told uncinate involved was not involved. Okay, so these are all critical errors when you decide management of pancreatic lesion, especially as the neck. Okay, so that you have to be very thorough and you cannot be superficial or passing comments while reading a CT, especially in a proximal pancreatic lesion. Third thing is, when you decide on surgery also, your decision is based upon the actual location of the tumor, more or less. You decide mainly on that. And second is the nature of the lesion you are dealing with, whether malignancy and its aggressiveness. So there was error. So all these three areas, you had errors and you need to correct a lot in these areas. Okay, I request comments, closing comments from other panelists, please. Dr. Phani, yeah.
Yeah, Dr. Gulab, I would say that overall your approach was good. There's a scope for improvement in making the differential diagnosis, opening your mind when you're dealing with any particular area, keeping all possibilities in mind, and then you were on spot at multiple times. You were very fine there. But I think radiological assessment of the CT scan of the lesion, you need to think. All of us do that when we were students. We also get into that trap, and you were like stressed and have some anxiety. try to look for a surgeon's point of view. If you're going to operate this patient, what are the vessels, what are the difficulties you're going to face? So CT scan reading probably has to be improved.
Yes, sir.
And management part also to be sort of widened up. But overall, it was good.
Yeah. Thank you.
Dr. Phani, any comments?
And nothing else to add, Biju. Thank
Okay,
you.
I think there are no other questions from the other panelists or attendees. So can we close this session now?
Yes,
So
sir,
there
I
are
think we
some
can.
questions in Q&A.
Hello?
Yes, sir. So there are some questions in the Q&A section. 3 questions are there.
Okay.
One is whether a Burgers or Burns procedure can be done for this patient.
Where is that question? I don't know.
That's not really relevant question actually, but anything below that?
Is there any specific point area about the location to decide regarding Whipple's or distal pancreatectomy? They would want to know because the lesion is arriving very near the neck, how much length of the head should be left to contemplate a distal pancreatectomy in such patient?
Dr. Phani, you wish to answer?
Absolutely. I think if the majority of the head and neck are head and uncinate are free, there is no particular margin on the right side that in a distal pancreatectomy you have to stick to the area of the neck, or you can go a bit more medial. I mean, the beggars, burns, all these procedures, you can remove a bit more of the head to get a margin, especially in a low grade lesion. So when you basically what you need to do when you're dividing the neck, one thing is make sure you got your GDA in control. So it's not a Whipple's, but still at least you have to sling your GDA because you don't know how close you'll be going. And that's one vessel which you can injure and have torrential bleeding when you're transiting to the right of the neck. So have control of the GDA, but in terms of margins, in a benign tumor, you just need barely a few millimeter margin. So there is no particular, you can go a bit more into the head, and you can curve in a bit more into the head and core out a bit more of the head parenchyma, and you can get a margin. In this patient, you'll definitely get a head margin. That won't be an issue. And in terms of the body tail, I think that's an important point. See, central pancreatectomy, the leaks are not as morbid as the Whipple's because obviously it's inactivated pancreatic juice. It's a distal pancreatectomy kind of inactive pancreatic juice. But if you're, you can always say that if like Gulal, you could say that introp, if I feel that the planes are too inflamed and the pancreas is too bulky and it's not safe to do an anastomosis, I would just do a distal pancreatectomy, which is still a less morbidity than a Whipple's.
Yes, sir. Yes.
The point, probably, I also want to emphasize the same point what Dr. Phani told. It is not mandatory that you need exactly a vertical cut at the neck of the pancreas, especially in these sort of patients. You can have a little 30-degree or even more cut on to the right side turning, and your cut surface of the pancreas may be a little bit more flat and oblique. But that is perfectly fine for this kind of lesion because ultimately you are saving the duodenum and the pancreatoduodenal complex, which is a much less morbid operation in the long term. Yeah.
Yes, sir. Yes.
Thank you.
Any other comments in the chat box?
No other questions.
Okay. So
Thank you.
I think we can conclude the discussion and the case question. Thank you very much. We can close.
Thank you,
Yeah.
sir. Thank you, sir.
Thank you.